صوتي واضح يعني؟
اي والله دكتور.
اوكي، نبدي ان شاء الله. السلايد واضح؟
اي دكتور واضح ان شاء الله.
يا الله. بسم الله الرحمن الرحيم. Our lecture today is demyelinating diseases. Demyelinating disease occupy a unique place in neurology. Owing to their frequency, tendency to strike young adult, diversity of manifestation, and regarding the pathogenesis. The most common disease of demyelinating diseases is multiple sclerosis. At the beginning, what is multiple sclerosis? In general, multiple sclerosis is a degenerative autoimmune inflammatory disorder of the central. There is a predilection to the central, and nobody knows why demyelinating diseases have a predilection to affect either central or peripheral. Multiple sclerosis affected the central nervous system of unknown etiology until now, characterized by demyelination and variable degree of axonal loss. Lesion of multiple sclerosis are classically said to be disseminated in time and place. This is the characteristic feature of multiple sclerosis and differentiate multiple sclerosis from other demyelinating disease and other neurological disease in general. Look at the iceberg. This is reflect the danger of multiple sclerosis. The danger of multiple sclerosis is bigger than it appears at first sight. And you should know that early multiple sclerosis is not necessarily mild. Multiple sclerosis is an autoimmune disease. But this autoimmune disease may be due to, we didn't know exactly the etiology, the pathogenesis of this autoimmune disease. From the general look, this autoimmune disease developed in genetically susceptible individuals who have resided in certain permissive environment. Multiple sclerosis appear to be more common in the northern hemisphere, and there is some genetic susceptibility. The disease affected mostly young women. Both sexes, the incidence rise steadily from adolescence to the age of 35 and decline gradually thereafter. It doesn't mean that there is no multiple sclerosis in pediatric age group and in geriatric age group, but most commonly in young adults. It is one of the leading causes of disability in young adult. As I mentioned before, the etiology is unknown, but although the etiology is unknown, presumably involve interaction between genetic, environmental, and other factors. These factors, this multifactorial etiology triggering an aberrant autoimmune attack, resulting in damage to myelin and axons. So the first thing that we know about multiple sclerosis, the pathology of multiple sclerosis, is the aberrant autoimmune attack. But what is the triggering factor of that? We didn't know until now. So make the treatment is not ideal and directed toward the immune system, because we don't know what makes the immune system behave in this way to resulted in this disease. Pathology and pathophysiology of multiple sclerosis. At the beginning, there is an inflammation. Later on, the inflammation, with inflammation, we show the demyelination, the characteristic of the disease. Thereafter, a gliosis will appear, and ultimately there is an axonal damage, which is the hidden cause of the disability. The characteristic lesion is the plaque. This white dot in the MRI is the plaque, and maybe for 10 plaques, only one is symptomatic. So just like the iceberg, only 1/10 is appeared and 9/10 below the water. This plaque of demyelination occur most commonly in the special area. There's a predilection for periventricular region of the cerebrum, the optic nerve, the cervical part of the spinal cord, not all the spinal cord, the cervical part, the brainstem, and lastly, the cerebellum. The lesion of MS, the plaque, the white dot in the T2 MRI, characterized by loss of myelin, indiscrete, well circumscribed area varying in size from 1 or 2 millimeters to several centimeters. If we take the plaque under the microscope, axonal density reduced in the plaque compared to the surrounding white matter. So there is axonal loss from the start of the multiple sclerosis. Multiple sclerosis, or the plaque, the demyelination, started in the early stage. We called it acute lesion. In this acute lesion, the prominent feature is the inflammation, whereas the majority of the later on, the chronic MS lesion, inflammation is highly limited. The plaque with time is evolved, and evolved to what? To be a chronic lesion. In the chronic lesion, adding for limited inflammation, there is a gliosis, and the gliosis started at the periphery of the plaque and advanced toward the center of the plaque. For this demyelination, if the axonal survived, not all the axonal is damaged. We said in the plaque, there is reduced in the axons. Some axons is damaged, and that's it. It's dead tissue. But the survived axons in the early stage of multiple sclerosis, there is oligodendroglial progenitor, which is differentiated to oligodendrocyte, which synthesized the myelin. So there is remyelination. But the new the new myelin in remyelination is not like that in original myelin, but still in the early stage when there is a remyelination, and I hope one day we found a drug to enhance remyelination. With remyelination, there is improvement in the severity of the manifestation. Maybe not regain the normal function, but there is definitely an improvement in the acute MS lesion. With time, there is axonal damage, and the severity or accumulative axonal damage increase with time. At the acute MS lesion, the axonal damage due to inflammation. So, if it is due to inflammation, we can decrease this inflammation to make the survived axons as much as we can. But in the chronic lesion, when there's no remyelination, there's a gliosis, there is a progressive, steady axonal damage, which is caused the permanent deficit in multiple sclerosis and a progressive neurological deficit in multiple sclerosis. With demyelination, there is myelin injury, blocks the saltatory conduction through myelin axons. The transmission of impulse is like in this figure. We put it, the transmission of impulse like jumping off kangaroo. But in demyelinating, the impulse is unable to transfers in this demyelinating area. So it will be very slow, like that of tortoise. It was kangaroo and become tortoise. Partially demyelinated axons, not completely. If there's completely, there is no transmission of the impulse. But in partially demyelinating axon, there is discharge spontaneously. The myelin, the main function of myelin to transmit the impulse, not form of impulse. In partial demyelination axons, discharge spontaneously, and this is behind many clinical manifestations. So, after this prelude for this subject, and according to this pathology and pathophysiology, what is the clinical feature of multiple sclerosis? Multiple sclerosis cause variety of neurological symptom and sign. Virtually every neurological problem has been described in multiple sclerosis. Yani, many neurological manifestation is unrelated to myelin, like movement disorder, but rarely, even this manifestation, which is unrelated to white matter, may be found in patients with multiple sclerosis in a way or another. So any neurological manifestation can be found in patients with multiple sclerosis. But there is common symptom and signs. Altered sensation, all type of sensation is very common in multiple sclerosis. So this manifestation, put it from upward to downward according to its frequency. Altered sensation is the most common, and cognitive dysfunction is the least common, but can be found. Adding to the clinical manifestation, there is something called heat sensitivity. The myelin is affected by the heat. And please remember this tendency, because later on, when we want to diagnose a case of the multiple sclerosis, we should know that maybe this is not a genuine manifestation. This is due to heat sensitivity. Although it's not common, one of the manifestation of multiple sclerosis is internuclear ophthalmoplegia. Internuclear ophthalmoplegia, one of the neuro-ophthalmic manifestation due to defect in gaze, defect in the gaze. What happened here is defect in internuclear ophthalmoplegia that make the patient difficult to adduct one eye here. He cannot adduct this left eye. With right eye have nystagmus to the right. This is internuclear ophthalmoplegia due to defect in medial longitudinal fasciculus. Characteristically, anatomically, medial longitudinal fasciculus pass upward from the pons to the midbrain in the medial part of the right and left pons. So it passes together, the right and left, near to each other. One plaque of demyelination can cause bilateral internuclear ophthalmoplegia. So bilateral internuclear ophthalmoplegia can give a hint. There is no pathognomonic, no diagnostic sign, but it gives a hint that this lesion definitely not vascular, because vascular affected only one side. The type of the lesion that pass to both sides in the same time is demyelination. Maybe tumor did that, but pontine glioma is not that common as multiple sclerosis. So bilateral internuclear ophthalmoplegia give hint that the patient have multiple sclerosis. There is manifestation due to spontaneous discharge from partial demyelination, which is paroxysmal symptom, tonic spasm, hemifacial spasm, and trigeminal neuralgia. Tonic spasm, hemifacial spasm is motor. Trigeminal neuralgia, and you should know what is trigeminal neuralgia. If it is found in young patient, it gives hint that patient may have multiple sclerosis, especially in female. Athos phenomena due to heat sensitivity. This phenomena that showed worsen transiently of existence manifestation. Heat sensitivity is experienced as appearance of a new symptom or worsening of a pre-existing symptom on exposure to heat. For example, a transient visual blaring maybe become apparent during hot shower or with physical exercise. This heat sensitivity causes exaggeration of pre-existing manifestation. In multiple sclerosis, due to special courses is course of the the timeline table is important, like of the clinical manifestation itself. The most common type, the classical type of multiple sclerosis, we call it Charcot type, because Charcot, a French neurologist, described multiple sclerosis 140 years ago in Paris. It is relapse remitting type. 50% up to 70% of the relapse remitting type progress to what we call the secondary progression. The relapse remitting, the reservoir of the oligodendrocyte is ended. So the patient has started to have accumulative deficit. We call this secondary progressive. Many patients have relapsing progressive. What do you mean by relapsing progressive? There is a relapse, a dipping, a new attack, but not improve. There is no remitting. And the progress to, and with further progression later on. There is a 10% of the patients of multiple sclerosis have primary progressive. There is no relapse remitting. It is a steady progressive of a neurological deficit. Marburg variant, the malignant, we called it the malignant multiple sclerosis. There is dissemination in time and space and from the start and aggressively. So we called it the malignant multiple sclerosis. Clinically isolated syndrome is the first attack of multiple sclerosis. And here, the patient presented to us with first attack. So how we can guess this is the first attack of multiple sclerosis? We said the treatment should be started as early as possible, but the patient presented with no classical course of multiple sclerosis. So we cannot diagnose multiple sclerosis so far. But we should have a criteria to select patients with a clinically isolated syndrome and start the treatment, because we can guess this patient will be a candidate of multiple sclerosis. The CIA is a clinically isolated syndrome, the first attack of multiple sclerosis clinical presentation. What is it? Optic neuritis, myelitis, brainstem syndrome, hemispheric syndrome. First attack of multiple sclerosis may be one of these 4 types, but optic neuritis is the most common presentation of clinically isolated syndrome. This diagram shows the evolution of multiple sclerosis. There is a preclinical stage, and this preclinical may be found accidentally, that the patient did an MRI for something else and found to be have a plex of multiple sclerosis, but he didn't have any attack. This is the clinical, this is preclinical stage. The patient didn't reach the threshold to get a manifestation of multiple sclerosis. Then the first attack is clinically isolated syndrome, one of these 4 types: optic neuritis, myelitis, hemispheric, and brainstem. Then the patient start to have relapsing remitting attacks, then resolve, then attack, then improve, and so on, to reach later on the secondary progressive multiple sclerosis. This timeline of the multiple sclerosis nowadays changed by the treatment, the available treatment. But we should have a criteria to detect multiple sclerosis as early as possible. So if we said multiple sclerosis, the synonymous term should be early diagnosis, because early diagnosis, it means early treatment. Early treatment will change the natural history of the disease and at least delay the progression of the deficit. Yani if the patient started in the age of, say, 20, if I prevent him to be crippled and until the age of retiredness after age of 50, this is excellent. This is the good aim to be reached. Primary progressive multiple sclerosis. This patient do not experience attack, but only steady functional decline from disease onset. There is a term, we call it benign MS. In benign MS, being fully functional in all neurological system 15 years after the disease onset. But a considerable proportion of patients suffer from cognitive impairment, fatigue, depression, this ethereal manifestation. So how we can say he's benign, but he has cognitive impairment? So there's many controversy about using this term. Now, how we can diagnose a patient with multiple sclerosis with this diversity of manifestation, diversity in the course of the disease, and no definite available investigation to have definite diagnosis. How we can الرابط راح، يعني قد حاولت ارجعه تالي قلت هذا كل الوقت راح يضيع، فسويت واحد جديد. شنو اللي صار ما اعرف، ما عندي خبره بهذا الموضوع، يعني بعد خلص ما يربط، يعني فك وما ريكونكتد وما تصير، فيعني هنبدا حتى لا يضيع وقت بعد. واضحه عندكم
واضحه دكتور؟
ماشي. So we need a criteria to document dissemination in time and place, and no other explanation. Exclude other possibility, because there is no specific investigation. So this, also the investigation help us in documentation of dissemination, but not for specific diagnosis. So with any criteria, we should remember to exclude other explanation of the manifestation. If we take one attack, we say dissemination. So what is the attack? Attack is either subjective or objective for more than 24 hours. So, for example, the attack of seizure, which can be found in multiple sclerosis, seizure is not an attack because it's not continue for 24 hours. Relapse is defined as a new symptom lasting for 24 hours, or maybe it's worsening of a neurological symptom that had previously stable for at least 13 days. يعني كان عنده cerebellar ataxia, for example, and improved for 1 month or more, maybe months, years, and then have cerebellar ataxia again, say left side limb ataxia, it will be a new relapse. So it will be dissemination in time. Remission is not necessarily to regain to normal, but improvement, decrease in severity. So the attack, relapse, exacerbation, and clinically isolated syndrome is synonyms. Brain MRI and the spinal MRI, this is not invasive. Now it is have major part in the diagnosis of multiple sclerosis. Used to confirm the documentation in time and space. So we have now an MRI criteria for dissemination in time and space. Maybe we have, but nowadays for limited use and evoked electrical potential to disseminated confirm dissemination in space. As I mentioned, the heat sensitivity, we should pay attention that maybe this is not a real attack. There is no dissemination in time, and this is a pseudo relapse due to heat sensitivity, especially during any infection. Analysis of spinal cord, cerebrospinal fluid, we have an increase in protein, and specifically we have oligoclonal bands, and the number of oligoclonal bands, it is useful to document dissemination in time. If the patient have no dissemination in time and there is oligoclonal bands in the CSF more than 3, so we can consider it as dissemination in time. This is a table for using the investigation to document dissemination in time and space. So you can look here if the patient have more than 2 clinical attacks in 2 different occasions. So we have the clinically documentation of dissemination in time and space. No need for any investigation, even the MRI. But if we have 1 clinical attack, for example, like in CIS The MRI will have a crucial part, because we can document the dissemination in time and the space and start treatment with this patient. If we have no specific investigation and only criteria, when do we search for alternative explanation? And which patient? Okay, if there is any other explanation, the diagnosis will have question mark or the diagnosis. But there is some situation that we should look for differential diagnosis if the symptom localized to one area. Yeah. In other words, no dissemination in space. If the patient have younger than 15 years of old and older than 60, we should look for differential diagnosis. If the clinical course is progressive, so no dissemination in time. If there is lack of typical manifestation, for example, we said the most common presenting manifestation is optic nerve lesion and sensory manifestation. If there is lack of typical, we should search for differential diagnosis. If there is only subjective, normal neurological examination, if there is atypical manifestation, if there is presence of other disease, organic and psychiatric, if there is a prominent family history, although sometimes multiple sclerosis will be familial because of they live in the same environment, but prominent family history make us shift our mind toward hereditary disease rather than autoimmune disease. Prolonged benign course, normal or atypical MRI. Normal MRI, I cannot say it's exclude multiple sclerosis, but it's very difficult to accept multiple sclerosis with normal MRI, especially with the sophisticated MRI nowadays, because the preclinical area there is MRI changes without any manifestation. Normal CSF, abnormal test, so many are false positive. The differential diagnosis could be vascular, non-infectious inflammation, infection, metabolic, neoplastic, degenerative, genetic, psychiatric, and other inflammatory demyelinating disorder. So we have a diversity of diseases that can mimic multiple sclerosis, or actually multiple sclerosis can mimic these diseases. Mortality, the multiple sclerosis decrease the lifespan of patients with especially severe multiple sclerosis 5 to 7 years from the normal population, but the morbidity is the main issue. So the aim of a treatment should be adding life to years, not years to life. He maybe live with and will be crippled from the third decade of life. What kind of life is this? But we should add life to years. The prognostic factor. We have factors that give a good prognosis to patients with multiple sclerosis. In female, the course will be usually benign. In early age is different, because in later age, if the multiple sclerosis started after age of 40 or 50, which is uncommon, but it will be more aggressive. Relapsing limiting definitely more than progressive type. Initial symptom, if it is optic neuritis, cranial nerves, sensory, it have more favorable prognosis than pyramidal, brainstem, and cerebellar insult manifestation. Now we reach the treatment. We should treat those patients as early as possible. because what is lost is not regained, definitely. Treatment. The treatment of multiple sclerosis defined into 3 categories. Therapy of exacerbation, the acute attack, the attack that have inflammation, a high level of inflammation. Then, treatment designed to modify the disease process. And lastly, the symptomatic management. Okay. Any treatment nowadays, although we have a treatment, we change the natural history of the disease, many patients live near normal for I can say decade. Okay, but there is still difference between ideal and reality of the treatment. Okay, we have the course, and I mentioned the course of multiple sclerosis, but the expectation on treatment response on clinical pre-treatment era, the progression was like in this line. Now, later on, when we started to treat patients in relapse remitting stage, the line decrease. So the disability decrease with time. So, and look at this period, for example, and I think you can guess the difference. Nowadays, we start the treatment from CIS stage, clinically as from the first attack. And you can show clearly that disability with time is decreased dramatically. Therapy of exacerbation. There is an inflammatory process, high inflammatory process during the acute MS attack. So we need high dose of steroid, and we treat the patient with methylprednisolone, and in some patient with plasmapheresis. Disease-modifying therapy. The long-term treatment for multiple sclerosis patients. The ideal treatment for multiple sclerosis should include remyelination. The disease is demyelination, so we should have remyelination, trigger the remyelination. And if there is myelin, the disease is demyelination, so we have myelin protection. But currently, this ideal treatment is under investigation and not use it in clinical bedside. Currently, approved treatment for MS work as reducing immune system activity or blocking entry of immune cell into central nervous system. So we have drugs, and plenty of drugs nowadays, more than 20. Immunomodulation, immunosuppressant, and immunoreconstitution. I don't want to go deep with this mechanism of action, but it is what I want to say. It has affected the immune system in different ways. Treatment as early as possible with disease-modifying therapy, mainly in cases with bad prognostic feature to prevent accumulation of disability. Treatment initiated after a first demyelinating event suggesting of MS with MRI evidence of disease activity delay the onset of a clinically definite. So, in patients with a clinically isolated syndrome, in those patients who cannot diagnose MS so far, but we will delay the change from clinically isolated syndrome, the first attack, to be a definite case of MS. And this is a very good aim. Neuroprotective factors may be one element of an effective strategy of MS. The earlier diagnosis of MS, the likely earlier initiation of treatment. We have a proposed treatment algorithm for multiple sclerosis depending on benefit, risk-benefit, and efficacy tolerability profiles. We have drugs as a first line. Failure of this drug, we will escalate to second line, and failure of the second line, we will go to the third line drug. Third line drug actually is drugs that have many side effects, and it is a broad spectrum immunosuppressive, not selective in function for those patients with multiple sclerosis. Lastly, there is symptomatic treatment. يعني I put it in the lecture بس يا ترى للاطلاع فقط يعني for any symptoms, and there is many symptoms in multiple sclerosis. We can give treatment for those symptoms. والالجوريثم بالمناسبة يعني الفيرست لاين second line, I want you to know that there is first line, second line, third line, but it's not necessarily to memorize the names of the drugs. And thank you for kind attention. ومتأسف على اللي صار، التأخير اللي صار يعني. Okay. And the door is open for your comments or questions.